The next session is Keynote Lecture 2. This session will be chaired by Dr. Naoya Sakamoto. Dr. Sakamoto, please.
Hi. Okay. Hello, I'm Naoya Sakamoto from Hokkaido University. It is my great honor to chair a keynote lecture delivered by Dr. Gregory Gores. Dr. Greg, hello, Gregory Gores. Hello, Dr. Gores.
Hello.
Hello. Okay. Yeah, Dr. Gores is a professor, chairman of a Mayo Clinic of Gastroenterology, Department of Gastroenterology and Hepatology. And now he's serving as editor-in-chief of hepatology and former president of AASLDs. He's conducting a wide variety of researches on basic and clinical researches on hepatobiliary diseases, and accepting and training many postdocs worldwide, including Japan, including my younger colleague, Takashi Kitagataya. The title of his talk now today is cholangiocarcinoma seeking of a cure. Okay, Dr. Gores, please start your lecture recording.
All right, thank you. Can you see my slide okay? Hello? Can you see the slide okay?
Hello, it's a great honor to participate in the APASL Liver Oncology Conference being held in Sendai, Japan. I wish I could be there with you. But it's really my pleasure to be with you today. I've been asked to speak about cholangiocarcinoma, and the title of my seminar is In Search of a Cure. I appreciate you taking this little trip with me with my friend Balduck Bob as we interrogate the biliary system in regards to its carcinogenesis. I will be speaking about cholangiocarcinoma, what we have learned, what should we explore now, and what are promising future directions. I want to emphasize that we have learned that there are multiple anatomic subsets of cholangiocarcinoma, termed intrahepatic cholangiocarcinoma, or iCCA, perihilar cholangiocarcinoma, or PCCA, or distal cholangiocarcinoma, termed DCCA. Each of these has a different genetic underpinnings, clinical presentation, and therapy. We now appreciate that intrahepatic cholangiocarcinoma arises from small bile ducts, that perihilar cholangiocarcinoma arises from large bile ducts and perhaps peribiliary glands, and is often characterized by mucus secretion as compared to small bile ducts. This would be a typical intrahepatic cholangiocarcinoma with a mass lesion in the left lobe of the liver. This would be a typical distal cholangiocarcinoma with a stricture in the distal bile duct and upstream bile duct dilatation. And this would be a typical perihilar cholangiocarcinoma. I will refer you to panel D in the lower right, where you, on MRCP, you see the obstruction of the right and left hepatic bile ducts with upstream bile duct dilatation. In panel C, you see transhepatic cholangiograms demonstrating that the left duct is completely occluded, and you will note the upstream dilatation on the CT and MRI scans in A and B respectively, but no mass lesion. So perihilar cholangiocarcinoma typically presents in the absence of a mass lesion. Most of what we have learned about cholangiocarcinoma is based on our knowledge of intrahepatic bile ducts. We still have yet much to learn about perihilar and distal cholangiocarcinoma. For many years, ICD classification lumped all these together or separated them either into extrahepatic or intrahepatic bile ducts. Most perihilar cholangiocarcinomas were classified inappropriately or misclassified as intrahepatic cholangiocarcinoma. To correct this, appropriate groups lobbied, and ICD-11 classification instituted in 2022 now separates these in distinct entities. This is a large publication, so patients from Europe, published in the Journal of Hepatology in 2022, and about 50% of cholangiocarcinomas are intrahepatic, and then the remaining equally divided between perihilar and distal cholangiocarcinoma in this study. In regards to intrahepatic cholangiocarcinoma, we now understand the landscape of genetic aberrations, and I will focus on two: the isocitrate dehydrogenase mutations, or IDH1 and 2, and the fibroblast growth factor receptor 2 genetic aberrations, or FGFR2 gene fusions. The co-mutational spectrum of actionable drivers in cholangiocarcinoma is displayed on this illustration. And you can see that about 15% of cholangiocarcinomas are IDH1 mutations, another 4% are IDH2 mutations, and about 10% are FGFR2 mutations. There are several mechanisms of genetic aberrations leading to oncogenic activation of fibroblast growth factor receptors, or FGFRs. The type 2 on your far right is the most common, which is an FGFR2 fusion, where the kinase domain is fused to a extracellular domain, resulting in constitutive activation, resulting in malignant transformation. These are usually non binding domains, non-ligand binding domains. There are several drugs which now target the kinase domain of the fibroblast growth factor receptors, one being futibatinib, and this is which is a irreversible inhibitor of the fibroblast growth factor receptors. This was published in the New England Journal earlier this year, and showing both substantial progression-free survival and also overall survival. There's a newer drug on the market called RYL4008, which is in development. It's a specific FGFR2 inhibitor, whereas the prior agents targeted all fibroblast growth factor receptors 1, 2, 3, and 4. In preliminary phase 2 trials, this agent has shown approximately 70 to 80% response rate, which is quite dramatic and better than that preceding drugs, which were in the US FDA approved and on the market. So we look forward to more studies with the relay drug 4008. Isocitrate dehydrogenase mutations are really quite interesting. Normally this enzyme converts isocitrate ultimately into succinate, which feeds into the Krebs cycle. But IDH mutations result in an aberration of the enzymatic activity such that isocitrate is metabolized to 2-hydroxyglutarate, which then blocks competitively the enzymes metabolizing alpha-ketoglutarate to succinate. And hence, this 2-hydroxyglutarate can be proposed to be an oncometabolite. We have several agents which have been developed to inhibit IDH mutations, and this is the one that's most studied, ivosidenib, and in a multi-center randomized double-blind placebo-controlled phase 3 study of substantial size, this agent was shown to enhance progression-free survival. So it's very important with intrahepatic cholangiocarcinoma, the genotype of patients, identify if they have an FGFR2 fusion or IDH mutation, which can be targeted pharmacologically. Okay, what should we explore now? We know that Cholangiocarcinoma is a highly desmoplastic cancer. And that desmoplasia results from fibroblasts intermixed throughout the tumor. And these fibroblasts have been termed cancer-associated fibroblasts, CAFs. We now know that there are 3 different subtypes of CAFs in these cancers. Vascular CAFs, which via IL-6 can promote tumor growth. There's an inflammatory subset of cancer-associated fibroblasts generating hepatocyte growth factor, driving tumor growth. And then there's a scarring, myofibroblastic CAF-associated subtype that secretes collagen 1A and hyaluronic acid, also promoting tumor growth. I believe that in the future, our ability to target cancer-associated fibroblasts will be critical in the treatment of this malignancy. Now, to highlight a clinical opportunity with these cancers, I've shown you a FAPI PET scan. And FAPI is a protein, protease, expressed on the surface of cancer-associated fibroblasts. And this can be conjugated. The FAPI, inhibitors of FAPI can be conjugated to radioactive material so they can be visualized by PET scanning. And this is a patient with a pancreatic cancer who's undergone classic FDG PET on the left and a FAPI PET on the right. And you can see that there's much more disease identified by the FAPI PET. So now we have a tool to be able not only to better identify the stage of desmoplastic cancers, but also because this can be tagged to radioactive agents, we probably have the ability to actually target cancer-associated fibroblasts in the future, which could be very helpful in this disease. So remember FAPI PET. Another interesting therapy arising for intrahepatic cholangiocarcinoma is neoadjuvant therapy plus liver transplantation. I will show you one study looking at this modality for treatment of cholangiocarcinoma. Small study of 18 patients. All patients underwent systemic therapy or local regional therapy or radiation therapy for the transplant. But at 3 years, 71% were alive. And so this needs to be further explored. Which patients, which neoadjuvant therapy are questions that remain open, but this needs to be broadly explored for the treatment of patients with small intrahepatic cholangiocarcinomas, often occurring in the setting of advanced liver disease, unresectable, and disease limited to the liver. Okay. So what are the promising future directions? And I feel like one of our forefathers at the Mayo Clinic, William J. Mayo, I'm looking through a half-open door into the future full of interest, intriguing beyond my power to describe. But the door is still half open and we don't have total clarity of what we need to do or what we may learn in the future. So as I said, the cholangiocarcinoma is a highly desmoplastic cancer with a rich stroma. And here you can see that there are glands, very rich pink appearing stroma. And in this stroma, there's a variety of cells. And so this is a tumor with a very rich with a very rich tumor microenvironment. So what have we learned from this using checkpoint inhibitors, which are currently used in a variety of cancers and are FDA approved for multiple cancers? So this is a study that Dr. Katie Kelly published in The Lancet this category year using a checkpoint inhibitor, pembrolizumab with gemcitabine and cisplatin versus placebo plus gemcitabine and cisplatin. And there's a small advantage for those patients who also received pembrolizumab plus gemcitabine and cisplatin. I agree it's not striking, but it was apparent. And based on the approval of pembrolizumab for other cancers and an established safety profile, this combination is now used in the United States. A checkpoint inhibitors really sort of unleash cytotoxic T cells or CD8 cells. We know that there are mucosal-associated invariant T cells or mate cells in the tumor microenvironment. There are tumor-associated macrophages or TAMs. We talked about cancer-associated fibroblasts. There's also tumor suppressor cells, FOXP3 T regulatory cells in the microenvironment. And so this is very rich, and it's also influenced by the microbiome and other factors yet to be determined. But understanding which cells are in the tumor immune microenvironment, what we can do to block or accentuate the activity of various cells, I think is a rich area of investigation and will clearly be lead to useful clinical strategies. And so when one begins to look at these strategies, we can have bispecific antibodies, which antagonize checkpoint inhibitors, but also antagonize TGF-beta, which is tumor suppressive in the microenvironment. We can have agonistic antibodies, particularly CD40, has been shown in preclinical studies to accentuate the immune attack on cancers. There's a variety of other molecules that can be targeted to sort of accentuate their anti-tumor activities, such as targeting MICA-B on natural killer cells. CAR T cells are being developed. You all know about the success of CAR T cells in B-cell malignancies, but they've also been developed for cholangiocarcinoma in preclinical models, targeting, for example, mesothelin or HER2. Anti-PD-1 and anti-PD-L1 therapy I've just shown you, but not as impressive as one would want. One wonders about combining it with local regional therapies such as chemotherapy, radiation therapy, combined checkpoint inhibitors with CTLA-4, or targeting with VEGFR inhibitors, such as is done in hepatocellular carcinoma. And then finally, people are using cancer-associated antigens, such as cancer testis antigens, as vaccines. They determine whether one can activate cytotoxic T lymphocyte cells by antigen presentation via dendritic cells. So lots of activity and lots of promise. And then I won't go into this because I reviewed it. And then I will show you other data on the TOPAZ trial, which was done in Asia and Korea, using gemcitabine for 6 months, then continuing durvalumab, another checkpoint inhibitor, indefinitely, as long as patients were responding. And this slide showed a better improvement, I would say, than the one by Dr. Kelly. This is a blue line is a placebo plus gemcitabine cisplatin, realizing that the drugs were stopped after 6 months of therapy. And continuing with durvalumab in the red line, and you see that there's a tail. So there's somewhere between 20 to 30% of patients who may have a long-term, a more durable benefit. And this shows the same data for progression-free survival. I really thank you for taking this tour of biliary tract cancers with me. I wish I could have been there in person. But this is a very exciting conference, very timely and topical, and I thank you for your attention.
And then, thank you to Dr. Gores, and very nice and very informative lectures. We'll accept the question from the followers. Yes. At first, you presented the two kind of therapies. One is a genome-based therapy targeting the IDH1 or FGFR2, and lastly, you presented standard of care therapy like GM6 plus durvalumab. In a clinical practice, which type of therapy you prioritize, or do you conduct general cancer panel for all patients before starting the therapies?
Yes, thank you. Thank you for your question, and thank you for the ability to share time with you today. We do genome sequencing on all the patients, but the IDH inhibitor and FGFR2 inhibitor have to be matched to those patients who have the respective mutations. But they're currently viewed as second-line therapies, so everybody gets the standard of care first with the gemcitabine cisplatin and a checkpoint inhibitor. And then if they progress on that and they have an IDH mutation, they go on to that therapy, and or an FGFR2 fusion, they go on to that therapy. There are currently studies determining whether that order should be reversed, but those studies are in progress.
Thank you. Yeah, also in Japan, the genome-based therapy has been implicated, but all therapies after the second-line treatment. Yeah, as far as I see the effect of the pemigatinib or IDH1 and 2 inhibitors, very good result. Maybe they could be used as a first line.
Yes, I agree with you very much. And the newer FGFR2 inhibitors are really quite striking.
Okay. Is there any other questions from the followers? Okay. Okay. Thank you very much, Dr. Gores, for giving us a very attracting and for the cure, very encouraging lectures. Thank you very much.
You're welcome.
Thank you very much, Chair and Lecturer.